I'm going to be introducing to you Jim Jorgenson, who is Associate Director of Supportive Care at Seattle Cancer Care Alliance. He received his BA degree from Loyola Marymount University in 1978, a Master's of Divinity from the Graduate Theological Union in Berkeley, California in 1983. After transitioning out of ordained ministry, Jim launched into a 27-year career focused on domestic and international HIV/AIDS care and prevention services, beginning with direct service provision and moving into program management at Washington State Department of Health and Public Health Seattle King County with the University of Washington. Jim is excited to have the opportunity now to support the healing and patient-focused work of SCCA, where he leads the effort of the social work, chaplaincy, patient navigation, medical nutrition, physical therapy, integrative medicine, housing and family assistance, retail, and the child life services. Please join me in welcoming Jim to the podium.
Thank you very much. Are you feeling a little full at this point? I know I certainly am. So I have never actually gotten on the wrong plane, but I have to say, the past 8 hours listening to a language unfamiliar to me and arriving in the midst of you at this point must be something like getting on the wrong plane. I did get the letters, and I got a few of the words, but this is all new terrain for me. I'm very grateful to be here, and more important than that, I'm grateful that supportive care is seen as a necessary part of this agenda. I know that at SCCA, and I assume for many of you, wherever you hail from, supportive care is an integral part of realizing the dream of the cancer cure. So I've been the Associate Director of Supportive Care now for just 2 years. It's been quite an adventure, an unexpected change of focus after those many years in HIV/AIDS. My parents both succumbed to cancer before they reached my age, and I saw you all doing the math when Kathleen told you the stats about my academic background. But my parents died in their 50s of cancer, and it's rather miraculous and magical to me that now I am bringing my career to a home stretch focused on caring for people with cancer like my parents. I should start with some disclaimers, or maybe disclosures are the appropriate term here. I'm not a scientist at all. 10th grade biology was the end of the road for me, and you can be sure that all day long I've been wishing I'd been paying more attention when I was in class. My graduate studies in theology didn't prepare me for the mysteries of oncological science. I'm here to tell you that I have discovered that there are mysteries more bewildering than God, and we've been pondering them today. Another disclaimer, I am the neighbor of Dr. Shannon Dorsey, but for those of you who know the backstories, we were not acquainted when she was a nun and I was a priest. So let's just dispatch that rumor right away. I have another apology to the earlier speakers who probably saw me on my phone all day long. I really have not been texting. I have been working Google like mad to get definitions to a lot of words that I have never heard before. So thank you for your patience with me. I don't know where Dr. Rodriguez is, but I'd like to order the first copy of your CAR T Cells for Kids book, because I think that's a good place for me to start. I'd like to invite you all to relax a little bit now and move into perhaps a more primitive part of your brains, and maybe into your hearts, because I'm no scientist, but I am very grateful to represent the extraordinary people who are working hard to deliver supportive care and attend to the whole person who steps forward for our care and support at Seattle Cancer Care Alliance. I'm very humbled to represent them. I am very fortunate to work with some really extraordinary people. Now I have to see if I can handle this technology. I'm pushing the wrong buttons. There we go, okay. So last month, perhaps those of you who are local to the area may have seen this Seattle Times article about immunotherapy at the Hutch. And Dr. Gilliland, who spoke with us this morning, is quoted extensively there. The article's main statement is that we're on the cusp of a cure by 2025. And even this morning, Dr. Gilliland said that that's a provocative message, and indeed it appears to have been, and a pretty audacious hope, I think. It's a breathtaking assertion, and I'm shocked to be living still in a time when we may live to see that day. Ironically, I think our advances in immunotherapy suggest that a cancer cure may come well before we crack the mysteries and challenges of supportive care. I think our motto there as the Supportive Care Division is caring for whole lives so that lives are whole. I think we have a long way to go beyond the cure for cancer to ensure the wholeness of those who turn to us, the wholeness of our own lives. Homelessness, poverty, anxiety, depression, hopelessness, loneliness, fear, estrangement. The realms into which we push in supportive care seem ever intractable, more of a puzzle even than cancer sometimes, and I'm hoping maybe someday we'll get our moonshot. No matter our progress toward a cure, our patients come to us with all their traumas, all their burdens, all their disappointments, and all their unfinished business laid bare. And it's ours together to create for them a container for their whole selves, not just their cancer cells, to hold them through this stage of their life journey, no matter how short or long that is. Cancer, whatever the variety, like HIV in 1988 when I started my work in AIDS, is now still the end of life as we knew it, whether death comes soon or later. It draws a line in our lives before and after. And as scientists and clinicians and providers like yourselves work on a cure, supportive care partners with them, with you, to ensure some measure of healing for our patients, whether or not we can cure them. Supportive care, I think, then, is about heart and soul, patience and mercy, empathy, listening, encouragement, understanding, grace, grit, and gumption. Those aren't scientific words, and I don't wager any of you are looking at your Google right now to get some definitions. Cancer and cancer treatment is a journey to the heart of the matter, to the heart of the human condition, to all that wounds and heals us, and that's a journey our patients take, but not alone, because we're taking that journey right along with them. There's a lot of support and care needed to get us all, patients and providers, over the summit. And I'm so honored to be part of that piece of the team. I know it's safe to assume that you all appreciate the place of supportive care in cancer treatment. But I want to note at the outset here the difficulty of the term. There's no generally agreed upon definition of supportive care, and depending on where you look, where you work, who you ask, supportive care can essentially be anything that isn't oncology. But I'm going to try to narrow the boundaries for this conversation. I also want to emphasize that supportive care isn't just a division or a program or a combination of programs or a particular subset of the staff of a cancer treatment center. Supportive care is something that we all do, and it's a responsibility we all have. And it's not so much the kinds of things we do as the way in which we do what we do. Whether you're nursing or counseling or pushing a wheelchair or dispensing a medication or cashiering at the bistro, you have an opportunity to provide supportive care, and I've both seen it extended and I've received it myself. I'm sort of departing from the National Cancer Institute's definition of supportive care, but I think it's important to note that care given to improve the quality of life of patients who have a serious or life-threatening disease. The goal of supportive care is to prevent or treat as early as possible the symptoms of a disease, side effects caused by treatment of a disease, and psychological, social, and spiritual problems related to a disease or its treatment. I think it's safe to say that we all know that we get to deal with a lot more than a disease, or even the impact of a disease on our patients or on ourselves. It's sort of a way into everything. And whether we are capable of addressing every need or not, they're delivered to us. I'd like to start with a little different definition of supportive care, and I've taken this from this wonderful book, The Emperor of All Maladies. I hope you've read it, or if you haven't, you soon will. Siddhartha Mukherjee. A patient, long before he becomes a subject of medical scrutiny, is at first simply a storyteller, a narrator of suffering, a traveler who has visited the kingdom of the ill. To relieve an illness, then, one must begin by unburdening its story. That speaks to my experience and aspirations as a supportive care provider. I left the priesthood as a young gay man in 1988. I knew a little bit about life's burdens by then, having shared in the disappointments and joys of my parishioners and struggled with my own. But my advanced studies were to follow. I was welcomed into the circle of HIV/AIDS supportive care providers early in the epidemic, when all you needed was fire in your belly and a willingness to step up. I was grateful for that, because what do you do with a Master of Divinity and no real experience that anybody would find interesting? It was pre-treatment in HIV and AIDS, and a lot of what we had to do was about end-of-life planning to ensure the gentle landing of our patients, of our friends, of our lovers, of people who looked a lot like we did at the time. AIDS then was at once a death sentence, and for many it was the revelation of secrets that killed the soul before the body. I became, much to my own surprise, an unofficial chaplain then, and often a funeral coordinator, working with families whose compassionate impulses collided with their religious beliefs, with no time to lose or to sort it out. Effective treatment wouldn't come until about 1995 or 96. But even now, HIV remains traumatic and life-changing, and it's another one of those experiences that draws a line between before and after. There were enormous burdens that faced our patients then, and so little time. I have to believe, too, just to plug the generous work of the many who I worked with over the last 3 decades, that the work that we did and that science accomplished during the years of HIV/AIDS must have had something to do with bringing this day sooner where immunotherapy is concerned. So much knowledge has been gained by sorting out the mysteries of the immunodeficiency virus. But anyway, however our brush with mortality arrives, it's traumatic and it's burdensome, and supportive care then is about unburdening. See, when I was a priest, I had 10 minutes because we had to clear the parking lot before the next Mass. But I may lose track of time here, so feel free to wave at me. Our patients bring their burdens to us, all of them, despite our inability to heal them all. It's ours to hold them, with them, even those that are beyond our curative reach. And for those of us who are in the healing professions, that can be very difficult, to see the needs that are beyond our ability to mend. That's the power and the pain and the privilege and the peril of the work that we do. And it gives us an opportunity to master our own humanity, to embrace our own limitations, to accept our own powerlessness, even as we try to lighten the burdens of those around us. Some of the challenges around cancer care just can't be cured on the genetic level. They're beyond the magic of treatment science, and that's where supportive care steps in. How do we ensure that the whole person and her concerns are being addressed? How do we prepare her body and her person to ensure the efficacy of treatment? How do we hold her other battles for a moment so she can focus on her cancer fight? How do we unburden our patients? We have an extraordinary team of unburdeners at Seattle Cancer Care Alliance, and Kathleen noted the services for which I've been responsible for the last 2 years, but we're at a juncture right now where we're reorganizing supportive care and we're bringing a lot more services under the tent. So I'm going to, for the first time in this half hour, talk about some things I don't really know about. In speaking of the services that we're bringing together to better integrate, coordinate, so that our supportive care wraps fully around the patients that are being treated at SCCA. Well, we are quite, I brought my glasses for a reason here. Addressing the supportive care needs of our patients, doing our work as best we can, enables all of you to do your best work. It's our part to align the stars and the services so that cutting-edge research like immunotherapy and the medical prowess of you nurses, clinicians, physicians, technicians can realize the promise of immunotherapy. So our goal as supportive care providers is comprehensive, readily available, integrated, proactive, fleet-footed, culturally appropriate, cutting-edge services. That's a big order. So at SCCA, we're very privileged to have a very closely integrated psychosocial program of care that unites psychiatry, psychology, clinical social work, and patient navigation. And I'm not going to be able to do justice to the extraordinary work of these teams, but I think one of the most unique components of our psychosocial programs is that patient navigators do a lot of the case management related work that is often associated with social work departments or discharge planning, freeing up our social workers to provide clinical care to our patients with supervision and consultation from our psychiatrists and psychologists. We have a lot of supportive services that are attempting to enable the successful treatment of our patients on the practical side. We're fortunate to have 150 units of housing in Seattle for short and longer term residency for people who come from out of area for treatment at a reduced rate. We have a financial assistance fund to support non-medical costs for patients. We have a robust volunteer program that serves directly our patient needs. There's no stuffing of envelopes or running Xerox by our volunteer programs. They all touch our patients. Physical therapy, medical nutrition therapy, chaplaincy, genetic medicine, and most recently, integrative medicine, bringing naturopathy, acupuncture, massage therapy, have been added to our team to, again, attempt to reach out holistically to our patients. Just around the corner, we're about to launch an onco-reproductive program that will attend to the fertility needs of younger people who are arriving for cancer treatment, often with very little time to make important decisions about their future as parents. Some of you have been in town for a few days may have noticed that we are also bringing to an end one of our supportive care programs, the 30-year Hutch School, which is a K-12 program that provided education to the siblings and dependents of folks who relocated to Seattle for their bone marrow transplantation. And now that transplants can be secured much closer to home for many people, the need for that program has diminished. But it's a heartbreaking juncture for the people that had made that magic happen for 30 years. How may we help you? How do we know, how do we identify and keep our finger on the pulse of the needs of our patients? Much still relies on the acute observation and the intuition of all of you. We've worked very hard to systematize distress screening so as to live up to our commitments for our Commission on Cancer certification. We do reach out, or we attempt to reach out anyway, to all of our patients upon arrival to assess their levels of distress around many criteria: anxiety, depression, spiritual pain, nutrition needs, mobility, social support, and practical needs like finance, transportation, housing, and education. We're working to make that assessment longitudinal, because we all know that the needs of our patients change dramatically over time. And that's all wonderful news, though as we improve screening, both initial and longitudinal, I think as we get better than knowing where it hurts, we're responsible for what we know. And we're going to have to ensure resources to meet the needs as we get better at identifying them. So what's unique to the supportive care needs of those undergoing cellular immunotherapy? I don't know, but we'll learn together. I can speculate a little bit, and I did so first by pulling this eligibility criteria for immunotherapy patients off of our organizational website. And from what I've learned today and what I've read before coming here today, the supportive care needs of these patients will be a variation on familiar themes, compounded by the cumulative burden of the homestretch, having tried and failed at many other treatments. Per these criteria, our patients will be advanced in dealing with recurrent or metastatic cancer, often at the end of a long journey after other therapies have failed. There'll be treatment veterans, and I suspect there'll be a cumulative weariness that we must attend to. A physician colleague with whom I spoke before today noted that in her experience and observation, at least for some of our immunotherapy patients, theirs is a journey through the valley of death. Last week in the New York Times, there was an article titled "A Promising Cancer Treatment Made Patients Worse, Not Better." And it reported the findings of a New England Journal of Medicine study about a particular checkpoint inhibitor used but not yet approved for treating a rare virus-related T-cell leukemia lymphoma. And I quote that article: "A sobering reminder that immunotherapy is still in its early days and can unleash forces that are not fully understood. Patients and doctors are eager to try the treatments when other options have run out, even in cancers for which they haven't yet been tested. Sometimes those Hail Mary efforts work, but they can backfire." I think that's where my question of Dr. Rodriguez was coming from earlier. What about dashed hopes? I know something about Hail Mary from my earlier vocation, but that's another presentation. But I do think that hope is a perilous thing, and we hold that hope as we hold our patients. Simultaneously with them, holding on to their dreams and yet sharing their dread. There are perils for us who do this work as well. This quote is from Susan Sontag, AIDS and Its Metaphors, from 1990. "Illness is the night side of life, a more onerous citizenship. Everyone who is born holds dual citizenship in the kingdom of the well and the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later each of us is obligated, at least for a spell, to identify ourselves as citizens of that other place. We, my friends, are dual citizens every day that we step into our work lives." While we share a common commitment to unburdening our patients, I think it's becoming increasingly evident that we need to address the supportive care needs of ourselves and each other. This is hard work. Everyone acknowledges it, but a singular focus only on our patients can be damaging personally and institutionally. I know at SCCA, the metrics by which we're measured as a division all have to do with our care for our patients. But we are called upon by our colleagues too. It's often our extracurricular work driven by our passion, not only for the work we do, but for each other. But I think, speaking only for supportive care at SCCA and for me, staff-focused attention to these needs requires resources that are not coming forward yet at this time. We don't have an owner yet at SCCA, and it's not us in our supportive care division, but we're hoping that soon to change, and I hope that in your settings as well, there is support and care for you and for each other, we citizens of both sides. I see a green light. I have 5 more minutes. Technology is an amazing thing. This is a screenshot of our staff support webpage on our intranet at SCCA. And I don't think you can make it out very clearly, nor can I without my glasses, but over on the far right, that column says staff well-being, and there are just 2 entries there. I think we need to direct our support and care inward as well as outward, as deliberately and generously as toward our patients. Beyond all the compelling arguments about the importance of supportive care for recruitment and retention of staff, it improves the environment of care and ultimately the care of our patients. And we can't give what we don't have. We need to find the money to take care of each other. I love this cartoon. Lassie, get help. We need it, folks. We need it, folks. As if our work wasn't difficult enough, not counting whatever you're dealing with in your own personal lives, we live in a time, I think, of increased ambient trauma. I know that's true here in Seattle, which is changing very dramatically. Having grown up here, it's unrecognizable in its scale and complexity. And that ambient trauma comes through the door at us and is in our patients. If you drive around Seattle much, there's tents along the freeways. We read of climate change and rising seas and school shootings and pedestrians mowed down. We all struggle with the political polarization and uncivil discourse everywhere we turn. And in the time I've been at SCCA, which I don't know if you've seen our clinic yet, but we're nestled right up against the elevated part of I-5, we've seen 2 pedestrians jump from the freeway to their deaths right outside the windows of our clinic. We live in hard times and we do hard work. And I think I've made my point, but we need to take care of ourselves and each other. As with HIV, which struck an already traumatized community, we first responders in those days found great solidarity and resilience in our coming together. And in face of all that we had so little control over, there was healing and power in being able to make some small difference, even if we couldn't cure our beloved ones. Now as then, as we stand powerless before so many of life's shadows, what a privilege we have to make a difference. And there's power in that and healing. I know now when I gather with my former colleagues from HIV, we're all a little long in the tooth. We talk about those old days. Most of my colleagues have aged out of the workplace, and I'm not far from there myself. But we have lasting bonds that were born of those times. And we talk aloud wondering, did those difficult years evolve us? Did they wake us up? Are we more conscious, more clear, more alive? Or are we really irrevocably damaged, diminished, numb? And I have to say, we are. And we can be both, damaged and resilient. And I hope we can find our way to that together, too. I'm going to zip through the end here because I've run out of time. I guess the question that occurs to me as a leader in supportive care is this: how well do I have to be to get your help? This is a question that comes up again and again when my colleagues and I are addressing the disruptive behavior of our patients and their caregivers. Most of the people that come to us for help with their cancer are dealing with many other issues. Increasingly, we're seeing patients who have severe mental health problems. They're dealing with chemical dependency. They're very hard to help, and they don't help us help them. What capacity, what resources can we put in place to support our patients and their other burdens so that they can realize the promise and miracle of our treatment? That's no small thing, because we're not behavioral health providers. We don't have a robust team of psychiatrists, psychologists, and such to address the acute needs that are beyond cancer as our patients come into our care. And yet I think as we realize these miracles that we've been talking about all day, the challenge for all of us is, how do we make them available to people who are hard to take care of? Obviously, this requires the response of systems far beyond cancer care. But I do hope that as your supportive care partners, we can work with you to ensure the lowest possible threshold for wellness of our patients so that they can get the cancer help that they really deserve and need. I'm going to bring it to an end now because I just got the red light. And I don't think I have much time for questions.
I would say, please, if you have questions, raise it, but also Jim will be here tomorrow. Oh.
Thank you so very much.